Welcome to AETCM, the Emergency Medicine channel. Today I have Dr. Satyajit from Department of Pediatrics with me, and today I'll be presenting a case of 7-year-old female child who presented to our ER with complaints of shortness of breath since last 6 hours prior to the presentation. On PAT examination, appearance of the child was sick looking, but the child was alert. On breathing, child was having increased work of breathing with suprasternal and intercostal retractions. There was also nasal flaring. On coming to the circulatory part, the color of the child was normal. There was no cyanosis or pallor. On 10-second assessment, airway was patent. Child was not able to complete a full sentence. There was no secretion, gurgling or pulling of saliva. On breathing, child had a respiratory rate of 40 per minute with a saturation of 85% at room air. And on auscultation, air entry was bilaterally equal and there was audible wheeze present. At this time, we had connected the child to O2 via the facial mask, and at 5 liter of O2, child was maintaining a saturation of 98%. At this time, we had also started with nebulization bronchodilator, that is with Astalin. The weight of the child was 24 kilo, hence 0.03 ml per kg into weight of the child was calculated, and child was put on nebulization Astalin 0.6 ml with 3 ml of NS with O2. Coming to the circulation, child had a pulse rate of 120 beats per minute with a BP of 102/72 mmHg. At this point of time, we had put an IV cannula. Capillary refill time was less than 2 seconds. Coming to the disability, child was having a GCOS of 15 out of 15 with pupils equal and reactive to the light. On exposure, child had a temperature of 99.9 degree, and at this time we had given child injection PCM. Usually IV PCM is given weight into 10, hence 240 milligrams of paracetamol IV was given to the child. GRBS was 110 milligram per deciliter.
Right. So at this point of time, if I can break and ask you, what did you actually treat?
Child had initially come with severe breathing difficulty, and on connecting to the monitors, it showed a saturation of 85%. So on 10-second assessment, we had understand that child was severely tachypneic, and then we had connected the child to O2. Via the facial mask we had connected, and on 5 liter of O2, child started to maintain 98% of saturation. And also on further evaluation, we had seen that the child was febrile also and had a temperature of 99.9. So we had given antipyretic IV PCM was given to the child after ruling out any allergic history.
Okay. So that means you were suspecting a respiratory kind of a disorder, yes, not a cardiac. No. And at the same time, you have also tried to treat and see that the hypoxia is somehow relieved with oxygen. You have given through mask, which is a low flow oxygen device. So which are high flow oxygen devices?
HFNC can be used. That is otherwise through HFNC is the high flow.
Okay, so HFNC is a costlier stuff because the tubings alone may cost around 8,000 rupees. So it may take time to get it and to install the machine in the settings. Better would be to also use a NRBM, a non-rebreathing mask. Your child is 7 years old and so will cooperate in the use of that. So that is what you will start, and your target saturation in such a child should be?
Between 94 to 98%.
Yes, so more than 94%. Anything less than 94% you call as hypoxia. Yes, that is true. And then you went ahead to do your primary assessment. Yes. And your primary assessment shows? In
the 10-second assessment, there was hypoxia and temperature was there. Then at this time, we had also done adjuncts to the primary survey. In that, we had done an arterial blood gas examination, but we only got a venous blood gas and it came to be as VBG, and it was showing a pH of 7.3 with a PCO2 of 50, lactate of 3, and bicarbonate of 24. It was showing a respiratory acidosis.
Okay, so that means ABG is basically another kind of a pulmonary function assessment, though it is invasive and painful for a child who is fully conscious, but will tell you the oxygen index virtually of a child, and because you've done a VBG, the oxygenation may not be fully reliable. However, acidosis will be told, and if you are supposed to make a rough estimate of knowing the hypercarbia, whatever is the value, you minus around 10 to 15 from that. So you said that the CO2 here was?
50.
50. Even if you minus 10, say it is around 40. So it's not so bad as we think it to be. Because in a child with a respiratory issue, you get a hypercarbia. So which are the respiratory issues? Basically like pneumonia or even in asthma, you can get where the parenchyma is involved or maybe the airway is involved. Fine. Then further assessment.
Further, we had also sent a blood investigation to know whether there was any infection in the child. So total count and CRP also was sent in the child. Coming to the secondary survey, 7-year-old girl presented to our ER who is a known case of reactive airway disease and not on any preventive inhalers was brought with complaints of shortness of breath since last 1 day and aggravated since last 6 hours. Patient was also having complaints of dry cough since 1 day and there was history of eating ice cream and cold curd 2 days back. Patient did not have any complaints of fever. Coming to the allergic history, patient was having allergy to the dust. Coming to the medical history, patient was previously on MDIs, that is MDA Asthalin 100 microgram 2 puff SOS and MDA Budicort 1 puff BD patient was initially taking, and after March, since the symptoms were relieved and since patient was asymptomatic, those inhalers were stopped for the child. Coming to the past history, child had recurrent episodes of cough and upper respiratory tract infections since the age of 1.5 and patient was always managed symptomatically, and since age of 3 there were regular episodes and all these episodes were treated with nebulizations, and patient on last episode was on January. Patient had presented this month. Last episode was on January, and at that time also patient was having acute exacerbation of wheeze, but at that time patient was maintaining saturation of 98%. So patient was managed with steroids and started on inhalers. But since patient became asymptomatic, slowly these were tapered and stopped on March. Then coming to the general examination of the
even
child.
Before that, so what are we finally dealing with? Which system is involved here?
Respiratory system.
Okay, so if that is clear, we need to categorize into basically one of the four. Either it is an upper respiratory involvement, or it is a lower airway, or it is a parenchymal, or it is a disordered breathing. So basically a central cause. So as per the history that you have, why do you say it is which part of this four?
Lower respiratory tract.
You think it is a lower respiratory tract involvement. Why? What are the points in favor from the
patient was having audible wheeze, and on auscultation also we were getting.
Yes. Even before that, let's look at the history. You have said there are multiple episodes in the past of cough, and hardly any of those episodes had fever. So that means they are non-infective etiology. And something very crucially and very smoothly you did present was eating of some food, some certain foods. So that we put into the category of triggers. So you have triggers. So what are common triggers that you have for, say, an asthma or a lower airway?
Usually in children, maybe any allergy to the dust, pollen mites can be there, any stress, anxiety issues can be there, any food intake can happen, exposure to cold can cause. All these are main triggers.
Yeah. So actually it goes to the power of N, meaning that anything that you use, anything that you inhale, anything that you eat, anything that you're exposed to, that means even the weather, the climate, cold, like you said, dust can be anything, even from cloth, even from paper, to the food you eat, preservatives, some to seafood, and also we are in the generation, dealing with generation X, so they use a lot of deodorants, perfumes, powders, all that. So anything can be a, to which a child gets exposed to is termed as an allergen. So that can trigger off the asthma. And when you say that there is no obvious trigger, you need to find out if there are triggers like stress, like you correctly mentioned, even sibling rivalry, unable to share a particular substance with the child, or not able to perform in school well, all that can trigger this kind of a spasm or a lower airway obstruction. Yes. Anything else that supports the saying that this is a lower airway involvement?
There was a trigger basically, then past similar histories recurrently happening in the child, and also then on taking the MDIs, these symptoms got relieved.
That's it. So you have a relieving factor. no case of pneumonia would get relieved immediately. Whereas a child who has a lower airway obstruction, and when you give drugs like albuterol, I'll always prefer to use drugs like albuterol or salbutamol than using asthalin and butyricod, which are trade names. So when these are used, you get an instant relief. That only shows the receptors are actually ready to respond to them, and they invariably do show a immediate positive response. So that again favors a diagnosis of a lower airway obstruction in this particular child. Okay.
Then coming to the general examination of the child was sick looking but conscious and alert. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Coming to the system examination, on respiratory system inspection, child was severely tachypnic, nasal flaring was present, suprasternal and intercostal retractions were present. There was no scars or sinuses. Coming to the palpation, trachea was central, vocal fremitus was equal in all sides. Respiratory movements, that is chest expansion, was also equal on all sides. Coming to the percussion, it was hyper resonant in all over the areas. On auscultation, air entry was bilaterally equal, bilateral wheeze was present, and vocal resonance also was heard equally in all sides.
Okay. So now from these findings, does it help in your diagnosis?
Yes, there is in lower tract infections there can be wheeze or crabs can be heard.
Okay. So you think it is an infection or it is a non-infective cause?
Non-infective.
Non-infective. So what findings support the diagnosis of, say, an asthma in this child as per your findings?
One is the previous history of similar episodes.
Only as per the
examination.
Yes.
Patient has a usage of the respiratory muscles, additional nasal flaring was there, usage of the intercostal muscles was there. Then on auscultation there was wheeze was present. Then on percussion hyper resonance was there. All those contributes to this.
Okay, so I think you covered most. Also, the child was tachypnic. Also, because the child is in acute exacerbation. Exacerbation meaning that the child already used to get several episodes in the past. This being yet another episode, and there was a trigger factor here. Okay, yes, you are right. So, what if you had a child and it was only hyperresonant on one side with reduced movement on that particular side? What would you suspect?
Then we have to suspend collapse. Pneumothorax.
Yeah, basically in this setting you can also suspect pneumothorax, provided also your saturation would have been showing much lesser. A trend of hypoxia would have been there. Yes. You did mention several things. Is blood pressure important in this child? Measuring blood pressure?
Yes.
Why is it important?
Patient can go into hypotension.
And or
tachycardia.
Okay, so you have also phenomena called pulsus paradoxus. Which also helps you to actually classify severe asthma into mild, moderate, severe and imminent life threatening. Okay, so once you have a pulsus paradoxus and if it is less than 10, it's taken as mild. If it is somewhere between 10 and 25, it is taken as moderate. And if it goes more than 25 to 50%, it comes under severe. Anything more than that is an imminent respiratory failure or arrest. Okay, yeah, so pulsus, BP is also very important. Right. Yes. So all this favors right now that you have a child who is in a state of exacerbation of a bronchial asthma. Yes.
So initially we had put the child on the O2. So with 5 liters, she was maintaining a saturation of 98%. Then we had started her on nebulization with bronchodilators. We had given Asthalin, calculated the dose according to the weight and given the nebulization. But even then, we had given 3 cycles over 20 minutes, each cycle over 20 minutes. Even then, she was tachypnic. So we had also given nebulization with Ipravent. Ipravent is usually given with a dose of 1 ml, 0.5 ml if the age of the child is less than 2 years, and 1 ml if the age is above 2 years. So Ipravent nebulization also was back to back given for the patient. And then we had also given injection hydrocot. Usually we give 4 mg per kg dose. So for this child we had given 100 mg hydrocot IV stat was given for the child. And child respiratory efforts slightly became better, but even then the symptoms were persisting. So we had admitted the child to HDU for further evaluation and management.
Right. So what have you been targeting here? You've been targeting with basic drugs like salbutamol, ipratropium, and the third drug that you said was?
Steroid.
So you are giving a bronchodilator. Why did you give ipratropium bromide?
because even with the short-acting bronchodilator, child was not becoming better.
Yeah, so it has a synergistic effect when you give both together. Agreed. There is another thing that you should keep in mind. When you give a drug like salbutamol and when you give a drug like iprapropium together, you could get tachycardia along with the disease process itself. The child is already is challenged with this particular problem. So you could use a drug like levosalbutamol, which has a lesser effect on side effect like tachycardia. Yes, and then you gave a steroid. Why did you give steroid?
Because it has an anti-inflammatory property.
Yes, anti-inflammatory. So you're actually hitting the very cause of the entire disease, which itself is defined as a chronic inflammatory disorder. Yes, so that's it. But you should be again aware that steroid can cause or could induce hypertension, can also induce hyperglycemia, right? So you need to be careful. Taking into account all the background, you have to use these particular drugs. Yes, okay.
So this child was admitted to our HDU, and following, since there was tachycardia persistent, we had changed the nebulization into Livolin nebulization, and then we had also given Ipraven nebulization. Like every hourly nebulization was given. Hydrocort injection was given every 6th hourly. When we give on 6th hourly basis, we take the dose as 2 milligram per kg. So 50 milligrams was given every 6th hourly for the child. And then since she was febrile, we had also started her on oral tablets for the child.
So what makes you to determine that the child should be sent home, admitted to a ward, or sent to a HDU?
Any patient coming to the ER with an acute exacerbation of bronchial asthma, first we have to classify into mild to moderate or severe asthma exacerbation. So based on the respiratory rate, when the respiratory rate is more than 40, when the pulse rate is more than 120, and when there is usage of the extra respiratory muscles usage is there, saturation falls below 92%, and when on lung examination, lung function examination, when the peak expiratory comes below than 50%, that is termed as severe asthmatic, and those patients should be admitted to the HDU and monitored. Patient coming with mild asthma, they can be given nebulization with the bronchodilators, and steroids can be given and then discharged.
Yes, so I think what you have done is summarize the entire thing. What I would add on is you would also ask for a few danger signs which you should ask in pediatrics, and that is a child having a seizure. Even though the child is able to do everything fine and looks okay, if the child has had a seizure because of hypoxia, or if a child is lethargic, okay, maybe because of hypoxia or because of the disease process itself, or if the child is inability to feed, not feeding at all, child is having incessant vomitings because of the choking like episodes, these are probable conditions when you will admit anyways, and maybe you will decide towards the HDU. If the child also has grunting, okay, so grunting is also a very terminal sign of respiratory failure, so you have to be very mindful of that, and you will be admitting in the HDU. So such kind of children you will not discharge, you will admit either in the ward or HDU, and like you correctly said, classifying on the basis of mild, moderate, severe, you decide to whether admit in the ICU or not. Okay, so which kind of children would require a respiratory support?
Even with the nebulizations and the steroid intake, if the child is not able to maintain the saturation above 92%, then we can give a trial of NIV for the child. And even with that, if the child is not maintaining, then we have to plan on mechanical intubation for the child.
Are there any other drugs that you could use even before reaching the NIV?
Magnesium sulfate can be given for the child. Usually we give in the dose of 50 to 70 milligrams per kg with a maximum dose of 2 grams in 100 ml NS. It can be given over 20 minutes to the child.
So what is the commonest side effect or a very treacherous side effect that could happen with magnesium sulfate that we should be aware of?
Hypotension can happen in the child.
So that is why it has to be given very slowly over a period of almost 30 minutes. You don't give it as a quick bolus kind of a administration. Yes, you're right. And apart from this, any other drug can be given?
Ketamine also can be
Ketamine, you need to be aware that it is a dissociative anesthesia. If the child has hypoxia and sensorium is slightly low, it could even push it lower. So you need to be wary of it. At this time, the child should already be in a minimum HDU setting, okay, where the child has to be under intense monitoring. The other drug you could possibly use is probably epinephrine itself, or even terbutaline could be used. Okay, that gives you actually time, because you've already used 3 to 4 drugs. You know that you are going towards a respiratory failure or arrest. The child is already pushed or moved into the HDU, and now you can administer drugs like ketamine also. So you're buying time by giving drugs like terbutaline or epinephrine. Okay, right. Yes. What are the complications that you should look for at the same time?
Whether the during the exacerbation child can go into severe exacerbation, so we should look for whether the child becomes confused, whether the child becomes drowsy, and it can go into silent chest. So we should never be mistaken that once nebulization is given and then we are not getting wheeze, it has the improvement of the child. We should always look for whether the child has gone into silent chest.
Okay. So what is the criteria for discharging a child from the HDU?
Once the respiratory rate comes below 30 for an elderly child, the tachycardia has come below, patient's effort, respiratory efforts has come down, when there is no cyanosis, when the child is fully conscious and oriented, then patient can, the drugs can be stepped down, and
Okay.
then after stepping down the drugs, then can.
Right. So when will you discharge a child home, and what advice will you give to the bystander or the parent?
Probably the bystander should keep a diary, an asthma diary, about the how many exacerbations are happening in 1 month, how many times the child needs to take the inhalers, that is on short acting. When we discharge the child on the inhalers, then how many episodes are there where the child is forced to take the inhalers. All those things should be written for the assessment.
Correct. Apart from this, whatever you have said, you can also train the bystander in using a peak flow meter, which is a very easy bedside usage. And by using a peak flow meter, a diurnal variation of more than 20% is more than sufficient to tell you that there is an impending bronchospasm. And then the parent can begin to use a short-acting beta agonist at home itself. So the child need not come running to the hospital to start the medication. We need to train the mother in that way. Okay. Is there any other drugs that you will suggest to such a child who's having multiple episodes in the past and to prevent it from happening in the future? Any drugs or any drug devices?
Inhale. MDIs can be given for the child.
Correct. So MDA, we are talking about a 7-year-old child who may not be able to coordinate the administration of the drug. So you have to advise the MDI
With a spacer.
using with a spacer and
And a
mask.
mask.
Okay. So this is as per the GINA guidelines, the Global Initiative
for Asthma.
for Asthma. Yes. So as per that, you have to give not only a SABA, you must give as per the newer guidelines
Inhalational corticosteroid.
inhalation corticosteroid. So a SABA and added ICS is the state of the recommendation. Okay, and that you give till the control is attained or achieved. And of course, we continue the monitoring by the peak flow meter at home. But you are supposed to advise the mother that a peak flow meter reading is to be done over a period of 3 weeks. Okay, once you do over a period of 3 weeks, you take an average of all these 3 weeks and then you call it something called a personal best. It is from that particular personal best reading that you start deriving for that particular child a 20% reduction in FEV1, which is recorded by the peak flow meter. And once that happens, there is an impending spasm, and the child or the mother should be giving the child a short-acting beta agonist immediately. Yes, you should also train the mother as to when they should come to you. So, failure of at least 3 back-to-back usages of the short-acting beta agonist in a span of probably an hour, 15 minutes, every 15 minutes, that gives the mother itself that much time to prepare to come towards the medical facility. So that is when the child should be brought. Okay. So the back of your entire mind, you should realize that all wheezing children are not asthma. Okay. So if a child comes with wheezing, what are the other etiologies that you would have in your mind?
In children, child age group, most common is the foreign body. So first we have to look for any foreign body ingestion is there. If the child is below 2 years, then we can look for bronchiolitis. Then any hypersensitive pneumonitis can cause wheezing. These things.
Okay. Are there any risk factors for asthma? Meaning that a child has certain risk factors and is really prone in getting multiple episodes of wheeze. Not just 5 in the past, but at least a dozen is waiting for the child to happen. So are there any other risk factors?
Any triggers?
Okay. So a baby in the childhood, the baby was born as a low birth weight. A baby born as a preterm. A baby who's had recurrent pneumonia in the past. A baby who has had in the background a tracheoesophageal fistula. A baby who's had bronchopulmonary dysplasia, BPD, which is again essentially a complication of a preterm, the stormy course that the child has had. A child who is continuously getting exposed to smoke, like passive smoking. These are all very essential risk factors. And like in the beginning, we talked about triggers. If the child is going into a background of having pets at home, basically with dander or dealing with toys, okay, which are having fur, these are all triggers. So they are all risk factors in which, of course, if there is a family history, then you know this child is prone for a long time. So you have to train the mother to keep the background safe and also treat the acute exacerbation and know when to seek help. Okay, they should always keep these medications at home. So you said MDI. Apart from MDI, is there any other drugs for the prevention of asthma? So we could use drugs like leukotriene antagonists. So they use another pathway. Okay, so you have montelukast, pranolokast, zafarlokast. Commonly available is montelukast. So that is also doable for a child. Okay, and of course the basic thing is you have to have prevention of all the trigger factors, right? Okay. So you should also remember that there are other differential diagnoses when you have a child with asthma. You should rule out cardiac disorders. You must rule out all the shunt disorders, like a large VSD can also manifest. You have a tracheostomal fistula, commonly is the H type, which gets masked. Okay, so you have to rule that out. A child who is immunocompromised, a child who has probably a ciliary dyskinesia. Okay, so such a child would also have otitis, will have sinopulmonary infections. A child who has cystic fibrosis. So it's a multi-system that gets involved. Right? So this also should be there in the mind, because otherwise we only treat for asthma and send back, and they come back with other problems in time.